Good afternoon, or morning if you're in any other time zone but the East Coast. Thanks for joining us today. We're excited to bring you the fourth webinar in the NIA Data Linkage Program's 2024 webinar series. Today, we are featuring the National Long-Term Care Survey, or NLTCS. The agenda for today's call is to start with a few brief introductions, followed by a brief overview of the NIA Data Linkage Program, and then moving on to our featured topic, which is the National Long-Term Care Survey. After the presentation, we will provide ample time to have a question and answer session. By way of introduction, I'm Susan Seifert. I'm the project director of the NIA Data Linkage Program. I'm joined today by Eric Stollard and Arseny Yashkin from Duke University. Given the current webinar format, we are requesting that questions be submitted via the Q&A chat box, which can be found in the lower navigation pane. The panel will do their best to answer all the questions, time permitting. If there are any questions remaining, our team will be happy to follow up with you via email. Next slide. Now for a brief overview of the NIA Data Linkage Program. NIA established the Linkage Program to address three challenges that researchers face relative to gaining access to CMS data for linkage to their study. The first challenge is the time and cost for researchers to access the CMS data. To overcome this challenge, NIA collaborated with CMS to structure this program so that it is able to provide quicker access to CMS data at no cost to the researcher. One condition, however, is that researchers must use the CMS data in a federally authorized system that meets all federal data security requirements. Finally, NIA recognizes that not all researchers are experts in the use of claims data. The Linkage Program offers a knowledgeable CMS data support staff to assist researchers in their questions. Next slide. Building on these challenges, the primary goals of the program is to provide the NIA-funded study and CMS data to authorize researchers in an environment that does meet all of the federal security requirements for the storage of CMS data, in hopes of facilitating high-impact research in the area of health and aging. Our comprehensive CMS data inventory includes Medicare enrollment data, Parts A, B, C, and D data, as well as the CMS assessment data, MDS, OASIS, and IRF-PI, and also the Medicaid data. Next slide. The CMS and study data are delivered to the researcher in the Linkage Enclave, which is a set of secure workspaces where researchers are able to analyze the CMS linked study data. Each project gets its own dedicated environment, which is accessible to only authorized members of their research team. Next slide. The Linkage Enclave offers a variety of statistical software packages such as MATLAB, Python, R, SAS, SPSS, and Stata. The Enclave also features a proprietary tool called the Job Board, which is a load-balanced, high-speed server farm on which your statistical packages can be run, often in substantially less time than running the program using local resources. The Enclave also features a file transfer tool that allows transfer of files into and out of the Enclave. Importing files is generally restricted to code and supplementary files as approved by the NIA study. Exportation requirements are aimed at supporting the dissemination of your research findings and are a bit more strict in that the data export should be aggregate level data with no PII or PHI and contain no small cells. Data transfers into and out of the Enclave require review by both the NIA Data Linkage Program and the study designated officials. The Linkage Program also offers a three-pronged support structure. The Linkage Contractor offers access to and support using CMS data, as well as Enclave support. NIA supports the researchers not only through its support of the linkage program, but also through the NIA DUA review and approval process for CMS data. And of course, each study team offers their study data and associated support. The linkage team can be accessed through email or via phone Monday through Friday, 8 a.m. to 8 p.m. Eastern Standard Time. I know that this was a ton of information that I just went through in a very short period of time. My team is always happy to answer questions and will be available during the Q&A session following the presentation. Now, with further ado, I would like to introduce Eric Stoller from Duke University, who will kick off the discussion of the National Long-Term Care Survey.
We have two presenters, myself and Arsini Ashkin. So I'm going to do the first part of the presentation, which will focus on motivating you to use the National Long-Term Care Survey data. I'm going to cover a whole range of topics which are described in my outline here. So I'm going to give you an overview. Specifically, I've been asked to address what does the NLTCS offer to researchers. And so I'm going to cover objectives, years available, data structure. The linkage to CMS data, as you will see, is really a crucial part of the ability to maximize utility of this survey, at least to maximize the longitudinal use, and you'll see how that works out. I'm going to give some examples and then indicate what data sets we're talking about before I hand over to Arsini. So that's sort of the outline. So the overview. So this is worth stating and actually just dwelling on it. The National Long-Term Care Survey, it's a longitudinal survey of a national sample of 49,000 or so elderly Medicare enrollees, with 6 rounds occurring in 1982, 84, 89, 94, 99, and 2004. After the beginning with the second round, the gaps were 5 years. That turned out to be the most feasible way to conduct the survey. The 82 and 84 rounds, those were sponsored by what was HICFA, called HICFA, Healthcare Financing at that time, and is now CMS. And then the remaining rounds were sponsored by Duke. All of the field work was done by the U.S. Census Bureau. So everybody knows and loves the U.S. Census Bureau. I'll point out some statistics to indicate how true that is. So the objectives were, the NLTCS evolved into a set of 6 closely related surveys of chronic disability, and they include health characteristics, Medicare, use of long-term care supports, along with a whole range of items addressing availability of personal, family, and community resources. And the key thing, again, is that this is a nationally representative sample of 49,000 adults enrolled in Medicare, age 65 plus or older during the 6 years. The sample size, I'm going to put up my laser pointer. You can see here there's a 49258. These slides will be distributed after the webinar today. So this is helpful if you're writing an IRB protocol, or if you're writing a grant proposal, just to have this information showing the race and ethnic breakout. You can see about 83 or so percent of the respondents are self-classified as white. Go on from here. At the beginning of 2004, there were 22,734 were still alive. And I checked from the linkage statistics. At the beginning of 2015, that number had dropped to about 10,000 people. And my estimate is at the beginning of 2023, that number is around 5,000 people. So that gives you a sense of how large the sample is, even 20 years after the last round of the survey. So there is much to be analyzed there. So what does the NLTCS offer? Well, large sample sizes. The sampling frame is the Medicare enrollment file as of April 1 of the designated survey year. It has a two-stage sampling design with a screener and then a detailed in-person interview. It's nationally representative, includes both community and institutional populations. That is, it includes everybody who was in the Medicare sampling list. There are some survey sampling weights that are provided with the file that permit cross-sectional analysis, and each survey year longitudinal analysis can use requires a more complex, nuanced use of weights, and in some cases you don't need to use weights at all. Okay, data characteristics. The main data characteristics we care about is that the linkage to CMS administrative data is 100% complete. And the reason for that is the Medicare administrative data serves as a sampling frame. Longitudinal follow-up on all subjects from date of enrollment to date of death is likewise 100% complete. So you don't lose anybody to follow up. That is very important, and it allows or it resolves a whole range of analytic problems, and that almost by itself is enough to motivate people to consider using these data. Probably one of the most widely quoted scientific papers, was Manton's 2006 paper in the Proceedings of the National Academy of Sciences. That's in the citations. The key result he had was that declines over the 22-year period, declines in chronic disability were very fast, about 1.5% per year. When we started this process, we didn't know if that was going to be 0% per year. That was certainly the view of many people, that we were in for a huge increase in chronic disability among the elderly population. What happened was there was a decline. This table here shows, or is pulled from Manton's paper, and the key numbers here are that we went from 26% at the beginning of the survey classified as disabled down to 19% 20 years later, and the decline rate was again around 1.5% per year. Okay, I did an extensive, along with my collaborator Anatoly Yashin, I did an extensive analysis, and we put out a 150-page report. So anybody using the data should know that we took great care in writing that report to make sure that any user could exactly replicate everything that we did. And so if you're going to use the survey, I would recommend that you take a look at this report, and it discusses in excruciating detail all the decisions that one would need to make to use these data. Because it was the Society of Actuaries, they were particularly interested, and I was particularly interested in how high-level disability, and high-level disability is the level of disability that meets the HIPAA ADL trigger, or the cognitive impairment trigger. And there's 6 ADLs that are very well known. I can answer questions if anybody wants to follow up on details of those, but that's the HIPAA trigger. And I do note that the HIPAA ADL rules exclude 57% of the traditional disability measures. So I commented here that the classification, only 8.2% of the population in 2004 met that level of, or that met the criteria to be classified as disabled at that level. And that 8.2 compares to the 19% that I showed on the previous slide. This is a typical table that we used, where we get the age, we get the year, and we look at the change, and eventually we compute an annual rate of decline. And you can see, depending on which way we do the age standardization, at 1984 or 2004 as a standard population, we got a decline of around 1.7% per year, which is a little higher than the 1.5%, but it certainly supports the 1.5% reported in Manton's paper. And I will point out here, we're always very concerned about precision. The t-statistics for these rates are incredibly high for the base rates, but even the t-statistics for the change are up near 10. So that's indicating that our measures are very precise. This is a graph. The blue is 1984, and the red is 2004. And this is by age from 65 to 95 and older. And no matter how you look at this, you would have to come to the conclusion that blue is higher than red. And that's the decline per year. You're looking at the 1.7% per year decline. That's a unisex figure. The HIPAA cognitive impairment trigger, some analysts will be less familiar. One of the key things is that it's comparable to Alzheimer's disease, and it picks up high levels of cognitive impairment without requiring an exact match. But at least that gives you an opportunity to look at Alzheimer's disease and related dementias and their impact on the population. The trigger is well defined. The references contain the site. It's actually the Internal Revenue Service put out these rules here. The cognitive impairment is simulated. The HIPAA trigger is simulated using data from the survey, and this slide here shows you how we did it, and you can go to the SOA report and you'll get the exact precise details of how we did that. So the changes. So the surprising thing from my perspective was that the changes, the annual rates of decline for severe cognitive impairment were on the order of 2.7 to 2.8% per year, a full 1% higher. And that is, in my view, and in view of all of the people that have looked at this material, is incredibly significant. The t-tests, very precise. We have good confidence in these results. Here's a graph. This is a unisex graph, and you can see that blue is much higher than red. So blue is 1984, red is the same age group in 2004. You can combine the two triggers, and in that case, we find approximately 10% of the population is disabled using the age standardized rate, and the decline rate is around 2.3%, intermediate between the 1.7 and 2.7-2.8 range. There's a graph, and again, every age indicates, or there is improvement at every age, a reduction in disability using the combined HIPAA triggers. This is unisex. And if you look for males, you see males have a large decline at every age, and you will see females have a large decline at every age. There's a little bump here at 85 to 89. I'm not sure how significant, or I haven't tracked that down, but I just pointed it out. So what's the takeaway message? There are big improvements in ADL and CI disability. ADL is 1.7% per year, CI 2.7, combined 2.3% per year, and there's a whole bunch of details that you can look at more leisurely after you get your copy of these slides. Compression of morbidity and mortality. I did a paper just almost simultaneously with the SOA report. Major finding of the empirical analysis are that the substantial slowdowns in the degree of mortality compression over the past half century, that was first part, was paired with an unexpectedly large degree of morbidity compression that occurred at least during the study period 1984 to 2004, and any theory of change would require that you should be able to detect some continuation of one or both types of changes going forward in time. That will be detectable in these newly released Medicare data, CMS link data. Okay, so if you're talking about compression, you normally look at a survival curve, a life table survival curve beginning at age 65. And so what I have here is a stacked line chart. It's called a stacked line chart with markers. If you go vertically up, it shows how the fraction of the population that is alive and is free of disability using the HIPAA criteria. If you go up one more mark, you find the increment to that count when you add in cognitive impairment alone. Go up one further and you add in ADL alone, and then you go up one further and you get ADL and CI alone. So we know from basic demographic methods that the area under the top curve is life expectancy, and the area under any other curve is years lived with or meeting those criteria. So this is what 1984 looks like. If I'm correct, and there is a morbidity compression along with combined with mortality improvement, you should see in 2004 that the top line moves up and all of the curves move closer together by some presumably visible amount. Big changes should show you that. So let's take a look and see what happens. We're going to jump from 1984 to 2004, and we see, yes, exactly as you would anticipate from morbidity compression, all the lines get closer and the top line goes up. So people live longer and the years spent disabled is shorter. Okay, we can actually compute these statistics. We can also, in this particular case, I wanted to look at the sensitivity of the different weights. There are different weights. The two that appear most plausible were the PNAS and the adjusted Cox weights, and these are described in the SOA report, and the change is either 0.6 or 0.7. So that gives you an idea. The unadjusted Cox weight, which we didn't recommend, was 4/100ths of a year lower, and there were some t-tests that were again up near the range 10. So these are very precise estimates. Okay, so the message here was we had big declines. The Duke PNAS protocol had the biggest decline at 28% of disabled. The years spent disabled declined by 28%, below 24%, and with the adjusted Cox protocol, and is just down below 22% with the unadjusted, but that was not recommended for technical reasons. Males and females also shared in the benefits of those declines. Okay. The decline in years spent disabled, that could be explained as a combination of reduced incidence or a change in survival after incidence. So in this figure here, we addressed what happens to the disabled population once we detect them at a survey. I took 1984 and 2004 as the baseline for this computation. I said, let's go 5 years out to 1989 or from 2004 to 2009. And this is a good example of using Medicare vital statistics data. And I took the disabled population in 1984 as a standard population and then computed age standardized survival. And you can see in 1984, the survival fraction was 38%, and that dropped to 31% in 2004. And that to me was we tested the difference, right? The standard error indicates it's quite significant. That was a big drop, and I wasn't expecting that. We tested for community and nursing home. So I'm not going to go into the details of these slides. We'll just point out we did it in 1984, we did it in 2004, And then we compiled all the different comparisons that were of potential interest. And in every case, there were big differences. Standard errors indicate that they're quite significant. And so large declines were found in survival rates for disabled persons based on this combined ADL cognitive impairment trigger. Now that might almost go opposite as to what people would expect, which is somehow that people at a particular level of disability would survive longer later. Our data is showing that that's not the case. And so whether we stratify by age or compare by sex or residence type, survey year, obviously 2004 had significantly lower survival. And that's a major component of what's happening in compression. Important point for today's presentation is that these data can only be accessed using the NLTCS linked CMS vital statistics or enrollment file. Again, this is a good example. This paper here is cited, and you can get the full citation in the references. The key thing here was we had a decline in the combined disability measure, and I wanted to see if there were differences if I broke it out into the pieces. So I had ADL only, cognitive impairment only, and then the combined ADL plus CI. And over here at the statistics or the p-values, you can see that male and female both had highly significant declines for the pair of ADL and cognitive impairment. Neither of them had a significant decline. In fact, 27 to 26% is nothing. 39% to 39%. The ADL only behaves very different than the combined ADL and cognitive impairment. And then there was a sex difference where the cognitive impairment alone showed no decline for males, but it had a sort of suggestive significance. 0.029 is suggestive. It's better than 0.05, but compared to t-values of 10, it's not compelling. But the combination of ADL and CI appears for both, because it's supported for both sexes, appears to be of particular interest. Okay, so that sets up a motivation. We know there's declines. We know ADL and cognitive impairments have different behaviors. So we can ask, okay, what else can you do with the survey? And so here's a citation for a validation of the Gen Frailty Index. There's several indexes that are built on CMS data. And this study showed that we can have a valid claims-based measure of ADL impairment and also of risk of long-term institutionalization. And that uses the MDS data to do the determination that someone is in fact long-term institutionally or meets the criteria for long-term institutionalization. Unmet need. I said there's lots of measures. Here's an example. The question 9 was introduced in 1994, but we find out if people don't get help, do they need help? Or if they do get help, do they need more help? So you got different ways of picking that up. And this is very significant because you can get this in 2004 following into a very extensive set of CMS data. Unmet need, okay. Unmet need was associated with increased risk for mortality, but only for those with 1 or 2 ADL disabilities and not with 3 or more ADL disabilities. That's a dichotomization even of the ADL trigger. The unmet need has apparently different roles there. Unmet need was associated with increased risk for hospital readmission. It was especially strong when it was for unmet need for new disabilities. Again, we can pick these items up. This is a list of the files that we had previously, almost all of those had been released at least through 2005. We had these files updated through 2009 or 2010, depending on the specific file. But we had all the Medicare A and B files, Medicaid files, and long-term care data files, and that's what we were working with. The new release, this is the files that will be available from Linkage, and you can see that the end years are through 2022, but very shortly we'll be able to extend those in time. But just getting to 2022, I had estimated that we had around 5,500 people still being tracked at that time. So with that, I will do my acknowledgements. NIA has carried the major absolute burden of funding this through a whole range of grants, and we are very grateful. The SOA study got some funding from SOA, obviously, that's Society of Actuaries. And then here's the list of references. One reference I didn't really get into was in the Encyclopedia of Gerontology and Population Aging. It's a short, about 6-page introduction, an overview of the survey that will give you some pointers if you're absolutely new. And with that, I think I am ready to stop my share and hand over to Arsini.
And I will go ahead and put my screen up. So I hope everyone can see the screen well. You should see a nice green slide. And what I'm going to talk about is incorporating CMS data into aging research, which what NLTCS is really all about these days. Everyone is quite aged, everyone that's in the survey. And since the last survey was in 2004, most of the newest data is coming from CMS data sources. Now, as I speak across my presentation, I want to remember two things. That as time passes, we have two effects. Well, one, the effect of the respondent aging. There's 65, then 66, 67, and so on and so forth. And simultaneously, the calendar year also cycles. And both introduce biases and potential effects into our analysis. So I went ahead and I plagiarized this slide from the fine folks at Linkage. Now, what I'm going to point out here is that although pretty much all of the CMS components, with some caveats, are going to be available, not all years are available for all sources, which introduces some very specific data analysis problems. So the Medicare enrollment data, by default, they're given 1991 through 2022. We are working on giving you the pre-1991 data as well. We have them in Duke, but there's some hurdles for us getting them out of Duke and into your hands. So the same thing for Medicare's Parts A and B. A very important Medicare Part C is available from 2015 only. So there has been an increase in Medicare Part C membership since its introduction. Early on in the 1990s, it's not that big a deal, and I'll talk more about this as we move along with the presentation. In the later years, right, especially in the 20s and in the late 20-teens, this becomes a very important part of the population, and not using this data may introduce some problems into your health trajectories. Of course, we got Medicare Part D data, which incidentally provides information independent of where you're in traditional Medicare or managed Medicare. And we have Medicare assessment data, which includes the MDS and OASIS. And as a sort of redheaded stepchild, we have the Medicaid data component all the way to the right, so I don't have to talk too much about it. So we're going to start talking quickly about the Medicare program. And this is a social insurance program for the U.S. elderly, and it covers 98% of the U.S. population age 65 plus. So essentially, it covers everyone legal, and I don't know which proportion of the illegal population. Because as many of us know, Medicare fraud does exist, and some people tend to live forever, and some people that shouldn't be there end up under a different name. So it does cover other types of people other than the elderly, but that's not necessarily a nationally representative slice of that population. A big plus of being able to link your Medicare data to an independent source like the NLTCS or any other survey that's Medicare linked is that you can ensure that you got the right people. Okay. When you got an absolute pure Medicare data source, you got that based off a social security number. At the NLTCS, we went into a lot of detail to make sure that the people that you see are the ones that you're supposed to see. So a lot of the theoretical problems you would have with a pure CMS data set, you don't have here. And I'll point them out as we come across them. So again, we have parts A, which is inpatient, B, professional services, D is prescription drugs. Then there's the managed care model, also known as Medicare Advantage or Medicare Part C. That's the HMO version of Medicare, and it's pretty much does the same thing. It's supposed to do the same thing, but it gives you more options in terms of maybe eye care, etc. Right. So we have some core characteristics. If you order the data, you will get Medicare data files, which are sorted according to these types of files. So the physician claims paid for by Medicare Part B, and the parentheses tells us the primary payer. Sometimes you have both, like in home health, both A and B pay into home health. But the primary payer is in parentheses. Then we have inpatient, skilled nursing facility, which is going to be related to MDS data, as we can see in the parents, outpatient, home health, hospice, and durable medical equipment, which is its own set of opportunities. Sometimes something called a MedPAR file is released, which is a composite of inpatient and skilled nursing facility. As far as I remember, at the NLTCS, we did not provide the MedPAR file, which is okay, since you get the inpatient and you get the skilled nursing facility file separately. Now, in 2006, you also get Medicare Part D prescription drug data. At the very beginning, that's 50% of the population. Nowadays, it's pretty much everyone. Now, if you did not have a useful survey, you'd get a very limited range of core characteristics, pretty much spelled out here. Since with the NLTCS, you can link to the survey the amount of characteristics from demographics or socioeconomics goes up quite a lot. Furthermore, you're not exactly limited by known limitations of CMS demographic data. Like, for example, 6 mutually exclusive categories in the later years. In the earlier years, you only had 3, white, black, and everyone else, right? So this evolved over time. What we get now, if you don't have a survey linkage, is white, black, Asian, North American, Native, other, and Hispanic. I think they might have also broken out Pacific Islanders, but my memory does not serve me well today. So, you know the months covered under each type of Medicare program, whether your self-pay premiums are subsidized by the state. This is useful if you don't have Medicaid data or if you don't want to dig into the Medicaid data to find out what's going on with an individual. It's a quick and dirty indicator of being very, very poor. We have zip codes of residence, which unfortunately we don't provide with the NLTCS. So you will not be getting these. You'll be getting a state level geographic indicator. But as of the releases available right now, we do not make the zip codes available. We may make them available in the future. Medicare Part D has its own separate denominator file, which is also quite useful. And again, 1991 through 2022 is what you get right now. In 1999, you also can get the minimal data set file, as well as the outcome and assessment information data set. Each of these is related to nursing home health, nursing home care, or home health care. Both are equally important, especially in aging, especially in the study of Alzheimer's disease over time, since one of the things that we learn about is that Medicaid and Medicare started trying to shift care into the home health setting from the skilled nursing facility setting. And you may be interested in finding out, well, how's that shift going over time? And the NLTCS is one of the few data sets that gives you a lot of over time, all the way from pre-1990. So the MDS is actually great. It provides a comprehensive assessment by a medical professional. So it's not exactly self-reported like the survey would be, of the functional, cognitive, and health status of all residents of Medicare, well, actually of CMS certified nursing homes. Since no one wants to run a separate tally of beds, pretty much most members or most residents in a nursing home will get this assessment regardless of who's paying, because it's much more difficult to figure out who's your payee and am I going to do the assessment or not than just give everyone the assessment. And many states simply required everyone gets the assessment. So there's two versions, the MDS 2.0 and 3.0. They overlap to a large extent, but you need to crosswalk them. There is a preliminary crosswalk made by RAND, which was done for the pilot versions and does not work in any shape or form to the final versions of the MDS 3.0. So if you use the first thing that you find on the internet, which would be the RAND Corporation crosswalk, apply it to crosswalk 2.0 to modern 3.0 data, it won't work. Right? You need to go into the instruments and crosswalk them themselves. So very extensive range of data, deserves its own presentation. I'm not going to spend time on it here. And it's linkable to the main Medicare claims files with a very high rate of accuracy. And since you have the NLTCS survey to cross-reference, you're going to get pretty much perfect accuracy here because you can always get them back to the seek number of the survey respondent. Same thing for OASIS. It's a much less detailed version of the MDS that's calibrated for home health care, but you get a lot of information from the OASIS. So the National Death Index can be linked to Medicare claims, but we don't provide it with the NLTCS. That being said, if you want to link it to the Medicare claims and then daisy chain it into the survey, just make sure you write something about that in your application. Personally, I won't have a problem with you doing that, but it doesn't mean that the people that sign off on the IRBs, not me, right, that they may not have a problem with this. But it's something that can be done if you want to cross-link to the National Death Index, maybe get a cause of death, which is in itself a useful thing. So again, I talked a little bit about there being two axes to the passage of time in our sense, a person aging and the calendar years ticking. So just quickly, if you've never worked with such data before, how can you identify a health trajectory that's useful? Well, you can use the denominator file. And if you have more than one denominator file, it's great to take a look at all of them. So usually, when you don't have a survey which removes a lot of these issues, you would exclude individuals living outside of the US. In the NLTCS, we're all here. This is not an issue. So first and last year of an individual Parts A and B coverage, some very rare numbers of people have only Medicare Part A. For example, a lot of the elderly Duke faculty, they'd sign up for Part A and then they'll use the Duke insurance. So that's something you can run into, something to be aware of. So it's also useful if you're Medicare Part A and B or Medicare Part C. Medicare Part C, before the data became available in 2015, only provided a very limited range of data. So it would provide the hospice data, for example. If you had a diagnosis which contributed to the hierarchical categories model, it would generally provide data on those diagnoses. But these sort of people were real difficulty for analysis, and most Medicare analysis would drop these. It's strictly not necessary. Now you can get, at least from 2015, Medicare Part C data. Keep in mind, they don't give you costs. And also keep in mind that even though you get Medicare Part C data, the plans are not the same. You're still stuck differentiating by plan. So eventually, after you do a lot of work and effort, you get something that looks like this graph down here. This is my visualization of what an individual health trajectory may look like, with you being eligible at 65. And again, this is roughly, depending on how accurate you want your birth date, you'll find out that a lot of people get into the data set at a fractional age. They're technically not 65, but they're already there. So the mileage can vary a little bit. 65 is what it says in the denominator file. If you take a birth date that's accurate to the actual day of birth and you calculate an exact age down to the day, you may get something a little bit different, and that's fine. So which plan did you go to? You could go to Medicare Advantage, you could go to fee-for-service, you can switch, and eventually you die. And with the NLTCS, Eric's slide showed us that for the most part, we know when our people die. And if they didn't die yet, not that many years left, right? Give it another 5 to 10 years, and the survey should be done all the way through. So this gives you a range of claims data availability. If you have Medicare Part C data to fill in those orange squares, that's great. If not, you have some unobserved periods, which you can try to get some information from, maybe from the survey, or maybe from the MDS, or maybe from OASIS, or maybe you can just squint and ignore it. And most of your analysis will still work as long as the censored windows aren't too great. So before 2015, only ICD-9 codes will be present in the data. After 2015, only ICD-10 codes are present in the data. 2015 is a wonderful year. Whatever the doctor wanted to do, that's what he sent you over. So it's a little bit, takes a little bit more attention to what you're trying to pick up, especially in SAS when you can run into variable lengths and censor some of your codes. So keep this in mind. We have procedural fields, which are available for the entire data range. Keep in mind, CPT and HCPCS codes share the same data field. So if you're looking for different data fields, you may not find them. Revenue center codes are also available. Personally, I like these less, but some people like these. For example, to study emergency room care. We have physician specialty codes, which also allow you to study outcomes by physician specialty. We have time unit indicators. So if you want to learn about ambulance trips, anesthesia use, and I have papers on these, you can go look them up by my last name. I'm not going to cite them here. But all of this is doable with Medicare data. And Medicare Part D also allows us to get into drug use. Just keep in mind, these are the things that you buy at a pharmacy, such as azithromycin, not something which would be administered at an outpatient location or a physician's office, like a pneumonia vaccine. Now, there's a lot of difficulties involved. You can't do a chart review. So what you see is what you get. And if a doctor a month later changes his mind, right, we don't see the change in mind. You just have to use a proper ascertainment algorithm. So, for example, a good example is wheelchairs. The rules say that they're covered once every 5 years, right? Most people use at most a 3-year look back for their claims algorithms. Even more people just look 1 year backwards. So if you use the 1-year algorithm or use a 3-year look back, you're going to miss a lot of people with wheelchairs because they cycle every 5 years. Another possible example is Zostavax, the shingles vaccine. Right? It's available in 2006. It's phased out in 2020. It's not covered by Parts A and B, but is covered Parts D. But since you're going to get it administered to you by a medical professional, you'll be looking for the claims in the Parts A and B file. Right, so it's a little counterintuitive, but there are some strange cases which occur in Medicare data. Again, they're not designed for research, which is why you should be aware of the limitations. And if you want to do something, go look at the literature. There's a lot of people that have been working on Medicare data since before I became a, what's the first one? First-year college student. I was a nice little baby scientist, and people were already working on Medicare data. So be aware of billing errors and delays, over and under coding, and tentative or mistaken diagnosis. So an interesting case of coding issues is morbid obesity being coded prior to bariatric surgery, which could, under certain model specifications, tell you that obesity is good for you. Obesity is not good for you, but bariatric surgery is something that's going to remove some of the negative effects for some time at least. And that's what causes that variation in model results. So it's not that the data is bad, it's not that obesity is good, is that you should be aware of how things are being coded in the data. Now, again, multiple claims for the same service are possible, especially in anesthesia. An anesthesiologist and an anesthesiologist assistant, if both are present, will both submit a claim for the exact same anesthesia. If you're counting both of them separately, you can double count your anesthesia, which is not exactly good. So now we go through these. So even with all these limitations I quickly went over, it's still an excellent source for aging research, especially for a data set which existed for as long as the NLTCS, because quantity is quality in longitudinal data analysis. The more uninterrupted years of data on the same people you have, the better off you are, and the less biases you encounter, or you can observe and document and model in your data. So if I sold you on getting on the bandwagon, what do you need to do? Well, this is another plagiarized slide, which I've modified it just a bit. And I modified it, the second box right here, the green one, which is associated with the study, which is myself and Professor Stallard. So how do you get the data? You do submit a study data request, which comes to us. And we will, 99% of the time, issue you a conditional approval. Because the only thing we require that you do is that you get a CMS or NIH DOA. Right? They're the guys that are going to okay you using the data. We want you to use the data. And if you're looking to do something, we are going to take the extra steps to ensure that you can actually do it. So I want you to use the data. Eric wants you to use the data. I find it difficult to imagine a reject from our side. So if you got your CMS NIH DOA documentation done right, and the folks at Linkage are okay with what you want to do, just write it out, send it to us, and we won't rubber stamp it. I guarantee that I'll read what you wrote if it's under 100 pages, right? And we'll approve it, and on you'll go into the flowchart. So this is my presentation, and I only left 5 minutes for questions, but that's it. So I'll